Welcome to the New Star Medical VEP webinar. Today's topic is anti-obesity medications. I'm very excited to be here as this is one of my favorite topics. We will review medicine, different types of medication we use in weight management, and become more familiar with when and how they are being used in addition to lifestyle changes. The objectives for today's webinar are to review the benefits of anti-obesity medications, to learn how the providers are customizing medications to help you overcome barriers to successful weight management, and to review the plateauing phenomena and how to break through it. Medical complications of obesity are all over. Dr. Lee Kaplan from Mass General has listed more than 70 illnesses that are the direct result of increased body fat. The idea that if you treat someone's weight, you can treat all of this has been clear to me for a number of years, but it has taken us a while to figure out how to do that without doing surgery or without diet alone. The medical complications have an impact also in our medication choices. We know that the risk of chronic illnesses increases dramatically with obesity, but the good news is that it also decreases rapidly with reduction in BMI. It has been known for a long time that a weight loss of only 5% body fat improves most of the conditions associated with obesity. Helping someone lose 5% of their body weight decreases the risk of developing type 2 diabetes by 50%. Getting them to lose 10% of their body weight reduces the risk by 80%. A modest weight loss of 5 to 10% is sufficient to prevent diabetes, improve glycemic control, reduce the need of anti-diabetic medications, reduce blood pressure and triglycerides level, increase HDL cholesterol and reduce inflammation, improve symptoms of sleep apnea, and improve markers of fatty liver disease. Unfortunately, obesity remains undertreated when compared with type 2 diabetes. Almost half of the adults in the US meet recommendations for anti-obesity medication. However, only 2% of those adults receive proper treatment. This is a large difference compared to the 8% of the US adults with type 2 diabetes, with 86% of them receiving medications. So why aren't we treating obesity more? Well, first, you have to recognize it as a chronic disease in order to treat it. Unfortunately, most people still believe that obesity is a disorder of willpower. Obesity has been first recognized as a disease by the American Medical Association in 2014, so not that long ago. This is the OMA, or the Obesity Medicine Association definition for obesity. It is defined as a chronic, relapsing, multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical, and psychological health consequences. If you ask where the disease is, I believe that the critical disease is affecting the hypothalamic signaling. This is the part of our brain that controls our hormonal signaling, hunger, thirst, temperature, sleep, and emotional activity. Certain foods can injure hypothalamic neurons. As a result, the brain becomes resistant to the complex hormonal signals that tell the brain how much we have eaten and how much fat we have stored. As a result, there is a reduction in satiety or fullness. There is an increase in hunger and interest in food, and this leads to a vicious cycle of weight gain. The weight regulating system gets increasingly biased towards weight gain and away from weight loss. So if you gain weight over the years, it gets easier and easier to gain weight and harder to lose weight because of signaling problems with hypothalamic pathways. And that is a disease in everyone's definition. Some of the reasons why it has been hard to find good treatments for obesity are the complexity of weight regulating pathways, the belief that obesity is behavioral and that people with obesity could lose weight if they wanted to, the high prevalence of obesity and concerns about misuse and potential side effects. Please remember this curve because this is how successful weight management looks like. We lose most weight in the first 5 to 6 months of following a diet. Then metabolic adaptation happens. This is our body's response to weight loss. We feel hungrier and less satisfied. As a result, we start regaining weight. The success is being able to stop the weight regain and maintain most of the weight we have lost. This is a 2-year trial comparing weight loss results on a low-carb diet, the blue line, the Mediterranean diet, the orange line, and the low-fat diet, the red line. In conclusion, Mediterranean and low-carbohydrate diets were found to be effective alternatives to low-fat diets and found to have more favorable effects on cholesterol and blood glucose control. Also, this study suggests that personal preferences and metabolic considerations can be very helpful to individualize dietary intervention to each patient. Let's talk a little more about metabolic adaptation, or our body's response to weight loss. 14% weight loss impacts 8 hormones that encourage weight gain, and these changes are sustained for up to 1 year following weight loss. On one hand, the hormones that promote satiety or fullness are suppressed by weight loss. And on the other hand, the hunger hormones production increases proportional to the amount of weight loss. This study showed sustained changes in appetite regulation peripheral signals were accompanied by increase in subjective appetite measures a year after weight loss. An important finding of this study is that many of these alterations persist for 12 months after weight loss, even after the onset of weight regain, suggesting that the high rate of relapse among people with obesity who have lost weight has a strong physiological basis and is not simply the result of voluntary resumption of old habits. The conclusion is that long-term strategies to counteract these changes are needed to prevent obesity relapse. There are clear treatment guidelines for weight management. The first one was released in October 2013 by the Obesity Medicine Association and is called the Obesity Algorithm. This has been updated every year since, and it is a very useful and comprehensive resource I use in my practice almost daily. In the same year, the Obesity Society, in collaboration with the American Hospital Association and the American College of Cardiology, published guidelines for management of overweight and obesity in adults. These were followed by the Endocrine Society, publishing their guidance in 2015. I passed my obesity medicine board in 2013, and at that time, there were a little over 500 board-certified obesity medicine specialists. And this year, the number has reached over 4,000 specialists. Despite of this, obesity medicine is still not a recognized medical specialty. So let's review some of the benefits of using medication for weight management. They help us make necessary diet and lifestyle changes. They help initiate weight loss in non-surgical patients. They can help stop weight regain or initiate weight loss in non-responders after bariatric surgery. Medication can be useful for maintenance of weight loss as well as body composition, and it also helps prevent recurrence or relapses and improve conditions associated with obesity. Most meds that we use for weight management fit in one of these groups. They can be centrally acting and impair dietary intake. They can act peripherally to impair dietary absorption, or they can increase energy expenditure. This is a busy picture that shows all the mechanism of actions for anti-obesity medications. As I mentioned before, they can decrease appetite and cravings. They can decrease leptin resistance, insulin resistance. They can increase energy expenditure. They can affect behaviors around food and increase dietary adherence and by mitigating biological and genetic factors. So as you can see, the appetite regulation is very complex, and this medication acts at different levels of this regulation. So the old treatment model is to treat chronic medical conditions first and wait last. This sometimes causes weight gain and becomes a barrier in the management of those chronic conditions treated. The new treatment model is treating weight first, as this will also improve associated medical conditions. The solution for medical-induced weight gain is early identification of those at risk for weight gain and early avoidance of those meds so that we never have to be at the point of dealing with weight gain because of medications we use to treat our patients. Some principles of medication use are: first, do no harm. Look for and manage medication-induced weight gain. Use medication as an adjunct to diet and physical activity to help compliance. A reminder here is that meds may not work without the right diet. Treat weight the same way we treat hypertension and diabetes. Weight management is chronic and needs monitoring. No medicine works for every patient. Use step care approach. Start with one medicine, then add a second one if needed. If the weight loss is less than 3 to 5% after 12 weeks of treatment, discontinue that medication and try a new agent that might be more beneficial to the patient. And finally, combination therapy will always be more effective than single agent therapy. These are the medications that FDA has approved for long-term use of obesity. So the first one is orlistat, that prevents absorption of 30% of the ingested fat. When used with a moderate to high fat diet, it can cause diarrhea with oily stools, fecal incontinence, and fat-soluble vitamin deficiencies. So needless to say, I have never prescribed this medicine, nor I intend to use it in the future. Lorcaserin or Belviq was a very helpful medication to control emotional hunger and binge eating. However, it has been pulled off the market a few years ago due to it being associated with increased risk of cancer. Phentermine topiramate combination, called Qsymia, acts as an appetite suppressant at the hypothalamic level, decreasing hunger, carbohydrate cravings, and decreasing urge to binge eat. And topiramate, part of it, also helps stop excessive thinking about food and cravings for sodas. Potential side effects of this medication are numbness, dizziness, drowsiness, insomnia, constipation, and dry mouth. Also, it can make carbonated beverages taste bad. This is why it's actually helpful if we want to decrease the soda intake. Moving on to naltrexone bupropion combination, also called Contrave. This helps with emotional hunger control. decreases carb cravings and cravings for alcohol or tobacco use, and also helps improve depression. Most common side effects are nausea, constipation, headaches, insomnia, and worsening anxiety. Now, the newer meds are liraglutide or Saxenda and semaglutide or Wegovy. These are part of the GLP-1 agonist class, and they have been very helpful in weight management. They slow down the gastric emptying and help increase fullness and decrease appetite without affecting mood, blood pressure, or interact with commonly used medications for anxiety or depression. They also have a cardiovascular benefit and help improve blood glucose control. However, they can be quite expensive, and they are injectables. Saxenda is a daily injectable, and then Wegovy is a weekly injectable. There are also medications used off-label for weight loss, and these are the sympathicomimetics, also known as phentermine, Lumira, or fendimetrazine. Again, these are the older appetite suppressants, and they're used on label for 12 weeks, but in long-term use, it is off label. They can decrease appetite and affect behaviors around food. They are helpful in decreasing carb cravings and binge eating behaviors. However, they can have a stimulant effect and can cause irritability, worsening anxiety, insomnia, and dry mouth. Metformin, on the other hand, is a very safe medication that helps decrease insulin resistance, decrease carb cravings, and optimizing weight loss on a low-carb meal plan in patients with insulin resistance. Side effects, most common, are nausea and diarrhea. Topiramate decreases carb cravings. It helps with binge eating behavior and thinking about food. It reduces soda intake and helps with migraine control. Most common side effects, as I mentioned earlier, are numbness, drowsiness, word-finding difficulties at higher doses. It's also known as Dopamax, hence we dose it at night, and it helps with insomnia. And there are generic combinations to mimic Contrave and Qsymia. These come close to the effects of the brand medications. However, they have more potential for side effects. Just a little bit more on metformin. This medicine decreases hepatic glucose production and increases muscle glucose uptake. It helps decrease the risk of progression from prediabetes to diabetes. It decreases insulin resistance, has potential cardiovascular benefit, and it's helpful to treat fatty liver disease. It can also decrease the negative metabolic effects of some long-term medications used for treating severe depression, bipolar disorder, and HIV. There are studies that are looking at this medicine potentially reducing overall cancer rate and help the treatment of multiple cancers. And it may enhance the effects of GLP-1 agonists like Saxenda and Wegovy when used for weight management. One of the things I look on my initial evaluations are medications that can cause weight gain and whether I can find alternative weight-neutral medications instead. Weight gain secondary to medication is a potential modifiable risk, and it's very common. Among commonly used medications that can cause weight gain are anti-diabetic, antihypertensive, and antidepressant medications. Other meds that can cause weight gain are anti-seizure meds, contraceptives, allergy meds, and steroids. Sometimes we can find more weight-neutral alternatives. Other times we cannot, or it's not advisable to change medication that work well. Using anti-obesity medications can offset some of the negative metabolic effects these meds have and promote weight loss despite of continuing the medication that can cause weight gain. It is important to individualize use of weight loss medications to match the specific barriers of each patient. We take in consideration patient preferences and medication coverage by health plans. The physician knowledge and comfort level to prescribe these medications are directly related to the amount of education and training as well as the experience with prescribing anti-obesity medication. As I mentioned before, real plateau is a result of complex metabolic adaptation that happens with weight loss. Medication combinations are always more effective than increasing dose of one medication alone. Utilizing additional tools from the 4 pillars of obesity medicine, which are nutrition, behavior modification, exercise, and anti-obesity medication, can help us break through a plateau. And don't forget time. Your body needs time to adjust to weight changes, and this can create frustration and increased risk of giving up on an intervention that has proven helpful. This is a summary of the anti-obesity medications. I'm not gonna go over it, it's a very busy slide, but I will have it in my office if you have questions about certain medications. I wanna thank you for your time.